Welcome to my presentation. My clinical intervention is low dietary salt intake in chronic kidney diseases by Sean McCaw. CKD is the abbreviated form of chronic kidney disease and is a condition where you don't have optimal renal function and is incurable. The severity of the condition is based on how efficient your glomerular filtration rate is. The higher the better. As you can see, stage 5 is end-stage kidney disease, and this would be where you would require renal therapy such as dialysis or a transplant. If you look at stage 1, don't be like, oh my God, I have a filtration rate of above 90 and I have stage 1 chronic kidney disease. Just remember that you've got to have some protein in your urine. That's when you know you have stage 1. So check your urine, people. I know I will. So how is this topic relevant to dietetics? Well, for one, it is mainly attributed by diet, and as a metabolic syndrome, depending on the stage of the condition, the metabolism of nutrients like potassium, protein, and salts are not properly absorbed or utilized. So the two main causes are diabetes and high blood pressure, which causes 2/3 of all cases of chronic kidney diseases. These two conditions are obviously known to be diet related as well. Salt restriction is not applicable to everyone with CKD, but the majority. However, sodium restriction has many benefits for CKD patients, such as reduction in blood pressure, proteinuria, and arterial stiffness. The diagram on the left shows what chronic kidney diseases causes and how it worsens cardiovascular disease and how this is a vice versa effect, and that's why these two diseases are closely related. The search strategy for evidence. So there was a number of databases which were used, and the first one was the Cochrane database, which is the leading resource of systematic reviews. So it's the best database for the highest quality evidence. Only one review was found that was recent. I then moved on to more specialized databases such as the BMC Nephrology and Heart. I found one RCT from each database, and the BMC nephrology is just relating to kidneys and associated disorder, and Heart is an international journal database relating to cardiovascular diseases. The evidence, okay, so the evidence was the highest possible NHMRC level-based evidence. So one was a systematic review of level 2 studies, which is the highest evidence source. The topic was in that systematic review was analyzing altered dietary salt intakes for chronic kidney disease patients. The last two were two randomized control trials, which is the second highest NHMRC level evidence on the hierarchy. So the second source was about creating a tailor-made program to help Bangladeshi background people reduce salts. And then the third study I found was about understanding the impacts of sodium intake on kidney function, fluid volume, and adipokines in chronic kidney disease. Okay, so the first two lines are just describing what makes an evidence base and what is meant by qualities. But the quality overall, the three pieces of evidence were high due to the large number of studies involved, how high the evidence base was on the NHMRC level, and the consistency of results. So they all found like there was reduced blood pressure, reduced proteinuria, and fluid volume decrease. The results were obtained through clinical science tests and good study designs, which is great. So the study designs will be seen later on, but some of the tests were 24-hour urine tests, the estimated GFR, the fluid status, and measuring the blood pressure using a cuff on the arm for the brachial artery. So the relevance was pretty good as well. So the purpose is trying to help the patients to understand the impact of salt intakes or chronic kidney disease and to see if this is an appropriate clinical intervention. So once again, quality is assessed by the possibility of a source being biased. So through the McMahon systematic review, it is strong because it considers all available evidence. There was 258 participants, which is statistically powerful. The higher the sample, the more accurate results, and this allows a hypothesis be based on the general population, any adult over 18 with any stage of chronic kidney disease. Obviously, once again, they have to have at least a bit of protein in urine in stage 1. The accuracy and reliability of systematic reviews are higher than individual studies. They talk about good study designs, and there was 8. So there was a lot to compare. There was the 3 parallel RCT, 2 double-blind crossovers, and then 3 normal crossover RCTs. The chances of results being influenced are minimized in these sort of reviews. All sources of bias and study design flaws are well analyzed. Okay, so now to the RCTs. These are the next highest level evidence. They're still highly regarded due to as more research would not likely change the confidence of the overall outcome. The comparison of 2 different groups can minimize false causality. Out of the 2 sources, one was a randomized parallel group control trial, and the other was a randomized control trial. The proper randomizations of these 2 RCTs will eliminate any possible population bias as well as minimize selection bias. Now on to the sources of bias. In the systematic review, there was a lack of heterogeneity amongst the patients in the RCTs. There was a little detail of what stages of CKD the participants were in and what treatments they were receiving, so it made it very confusing of how effective everything was. The attrition bias was present in some studies because they didn't make any accurate measurements or failed to record any changes of salt intakes, which influences the overall result of the systematic review. Comparing 8 studies is difficult to determine a definite result due to the large disparities of severity of salt restriction, duration of salt intake, and the methodological methods used. 2 RCTs reviews have the possibility of a carryover effect bias. The overall treatment can affect overall outcome. In this case, medication being taken in the start of the intervention. In the Brito-Azhar treatment, allocations couldn't be blinded, so this would create a selection bias as clinicians would select patients that they think would benefit from treatment or most need help from it. Only a single urine collection and blood pressure recording was done. To make this more accurate, you could have done a lot more multiple tests. You know, if a UC graduate did the test, the results would be all messed up, man. The difference between the control and independent group was that the independent group received education cooking classes while the controlled group just received a dietary advice and a general information sheet. The detection bias comes into play when they want the independent group to do better, to receive funding for the intervention, say, hey, our intervention's great, this is why. Both RCTs had a relatively small sample size, and this is a huge bias due to sampling error. There was also a carryover effect bias in the last evidence piece due to medication and order of giving different sodium levels, as the treatment order can be a huge difference. An overview of the sources of bias. What all studies noticed that not all the diseases were present or identified or recorded, so you don't know whether other factors went into play. The systematic review was too short, so this showed the limitation of not providing enough information of how low salt intake impacts on the end stages of chronic kidney disease, cardiovascular disease, and mortality rates. So to summarize the reported outcomes, salt did reduce the overall blood pressure and it reduced fluid volume and proteinuria. Fluid markers were greatly reduced from high to low sodiums, but adipokines were not much different. The independent group that received a lot more help did better, so that's the biggest plot twist I've ever seen. So what did I learn from the review of literature? There is no real adverse effects, but there was a concern for a slight cause of symptomatic hypertension. However, you can simply increase the sodium levels to avoid this. There's difficulty studying chronic kidney disease due to the high incidence of cofactors of cardiovascular disease. Hypertension is quite prevalent in chronic kidney disease, so the need for longer-term studies could be a significant clinical intervention for the end stages of kidney diseases. A reduction of 6 grams of salt a day, which is 2,300 milligrams of sodium, leads to a drop in blood pressure of 9 systolic and 4 diastolic. Thank you for listening. Keep calm and don't get salty. There are my references, and once again, thank you. Bye-bye.